Well, Harry, Dan, for the organizers, thank you very much for inviting me to for this opportunity to tell you briefly why I do think that routine monitoring of MRD and AML should be routine at this point. I have no conflicts of interest for this topic. So when I spoke with my friends the other day about MRD, I sort of realized that there's still a few that are unfamiliar with the concept of MRD. So maybe for this debate, let me propose a operational definition of MRD. At the very beginning, 40 years ago, the term was used, and I believe it still is, primarily to describe these leukemia cells which survive seemingly successful remission induction chemotherapy, but hide below the cytomorphological detection limit and are responsible for relapse. While it was early recognized that patients who achieve a morphological remission live longer than patients who do not, this interest in detecting MRD was prompted by the very recurrent observation of relapses in patients who achieved a morphological remission. This interest really was propelled by experimental studies that showed a strikingly linear relationship between animal survival and the number of transferred leukemia cells that were put into rats in this case. And the primary goal of this testing was very clear, was to identify the small numbers of leukemia cells in persons with AML that are morphological remission, and that would cause relapse if they were not successfully treated. And for the sake of time, I will not go into the discussion about the techniques, but suffice it to say for here that over the last 10 or 20 years, there's been a large amount of effort paid towards the development of flow cytometry-based assays to detect immunophenotypic abnormalities, as well as molecular assays to detect molecular abnormalities in patients with AML. And these methodologies are constantly improving, and they're rapidly evolving to this day, which is certainly one cause of major headache in the field. But I do believe that by now, MRD assays are applicable to almost, if not all, of the AML patients. So I noticed there's still a few people that are skeptical, fundamentally skeptical about MRD testing, but there really are a few reasons why you might be interested in MRD monitoring. For one, you might be interested in gaining refined information on the prognosis and the risk stratification of your patient. And somewhat related to this, you might be interested in using results from MRD testing to refine or perhaps even replace your morphological assessments that you do in the bone marrows at the end of a treatment. But there are other reasons you might be interested in the early detection and maybe the early treatment of relapse. Or more broadly speaking, you might be interested in using MRD data to direct your next treatment decision. And for the trialists, you might be interested in using data from MRD testing as an early surrogate for the efficacy of your study treatment. Oops, sorry, let me go back. So for the remainder of the time, I will show you data to support my argument to use routine MRD monitoring for the refinement of prognosis and for the treatment assessment of AML therapies. I do not think that there's enough data at this point to argue for MRD testing for early detection of relapse or for early treatment of relapse, perhaps with the exception of APL. I'm not aware of solid data that would tell us exactly what to do when you have MRD, how you treat it, or to use MRD as a therapeutic decision-making tool. And unless further validated at this point, there's not enough data to really say that MRD testing results are a good surrogate for clinical drug development. So numerous studies have shown over the last 10 or so years that results from MRD testing are at the cohort level of patients associated with outcome. And I've just picked one study to highlight this, published on several hundred patients by the Hovo and Sack group a few years ago, making the point that at many time points along the treatment, first cycle, during consolidation before and after transplantation, you learn something prognostically by looking at MRD testing. In univariate analysis, results from MRD tests were often the strongest adverse factor, and in multivariable analysis, often the only one remaining. And as I mentioned before, the MRD assays have evolved over time, and many different assays have been used to study the association between MRD test results and outcome. And it's remarkable how, despite this variability in testing, how remarkably similar the outcomes are in the studies. And this is maybe best exemplified by this study that one of our fellows, Sarah Buckley, did just earlier this year, where she looked at all the studies that we found that looked at the association between MRD testing before transplantation, post-transplant outcome. And while you appreciate some differences, maybe perhaps particularly in the studies that have used flow cytometry-based assays, perhaps as a reflection of the technological greater challenges there, overall the data really line up quite nicely.